Hello, hi everyone. The topic of today's lecture is impressions and jaw relations in RPD. The learning outcomes are you should be able to discuss the various impression materials used in RPD. You should be able to discuss the various types of impression techniques used for specifically recording partially edentulous situations. You should also be able to know the various types of functional support for the distal extension base, and you should be able to discuss the occlusal relationship for removable partial dentures and the methods to establish occlusal relationship, that is jaw. Now, support for tooth tissue supported RPTs evolves partially from the abutment teeth and partially from the residual alveolar ridge. So, special impression techniques are used to equalize as much as possible the support that is derived from the edentulous ridges, that is tissue support, and that which is received from the abutment teeth, that is called as tooth supported RPTs. Now, the impression that we take for removed partial dentures should record and relate the tissues under the same loading pressure, that is under the occlusal loading or functional loading. Under that condition, the tissues should be recorded. The impression should be recorded in such a way that the load is distributed over a large area, that is the distal seat area, so as to maximize the coverage of the denture bearing area and to prevent bone resorption and the unnecessary loading. You should also record the bases, that is especially in Kennedy's class 1 and class 2 situation, that is distal extension bases or saddle, accurate. Now, what are the various factors that affect the support in a distal extension base? That is in Kennedy's class 1, that is bilateral distal extension bases, and Kennedy's class 2, that is unilateral distal extension base. What are the factors that influence the support? So, first is the contour and the quality of the residual alveolar ridges. The second is the extent of the residual alveolar ridge that is being covered by the denture base. The third is the mainly the type of the impression technique used and how accurately it records the denture bearing tissues. Fifth or fourth is accuracy of the fit of the denture base. The denture base should fit accurately and intimately the denture bearing area where the teeth have to be placed without any distortion or without any gap. You should design the removable partial denture framework in such a way that it fits perfectly on the abutment teeth and there is no instability or rocking or rotation around the fulcrum. And the type of the occlusal loading that is available with the removable partial denture and the antagonist dentition. That is, you should have a cusp fossa relationship with the mandibular denture teeth arranged on the crest of the alveolar ridge with the central fossa of the mandibular teeth passing through the crest of the alveolar ridge and with a group function or a bilaterally balanced occlusion. Now coming to the first, that is the contour and quality of the residual ridges. The ideal ridge should support a denture base consists of the cortical bone with long parallel wall, that is tall rounded ridges, which is Atwood's classification 3, with a broad rounded crest and a firm fibrous and resilient connective tissue. There should be no loose flabby tissues, there should be no knife edge ridges. The next is the extent of the residual ridge that is being covered by the denture base. The broader the residual ridge coverage, the greater is the distribution of load to the underlying tissues in case of Kennedy's class 1 and class 2. Remember the snowshoe principle. And second, the denture base should cover as much of the residual ridge as possible and should be extended to the maximum amount within the physiological tolerance of the limiting structure. That is, it should extend to the full depth of the vestibule, to the buccal frenum, to the labial frenum, to the lingual frenum, to the alveolingual sulcus without impinging or without compromising the integrity of the limiting structures. The next is the accuracy and type of the impression technique that is being used. The residual ridge can be captured in two forms. That is in the anatomic form, that is when the tissues are at rest. The patient is not doing any functional movements like chewing, masticating, swallowing. That is, the tissues are undisturbed at rest, and this is the called as the anatomical form of the tissues. The second is the functional form of the residual ridges when the distal extension bases, especially the posterior residual ridges, are under functional loading or occlusal loading. The accuracy of the denture base, as I also mentioned, is very important for the support of the distal extension cast partial denture, especially Kennedy's class 1 and class 2. And this support is enhanced by intimate contact of the tissue surface or intaglio of the denture base with the tissues, firm resident tissues that cover the residual alveolar ridge in the edentulous areas, especially again Kennedy's class 1. The total occlusal load that is applied, which is the last factor, the support for the residual ridge should be optimized and shared with the remaining natural dentition as well as the denture teeth. This is affected by the number of the artificial teeth, that is how many teeth are missing, the width of the occlusal surfaces. Remember, to minimize occlusal loading, we have to use denture teeth with reduced buccolingual width in order to reduce and center the occlusal forces and to reduce the instability. And the occlusal efficiency influences the occlusal load, that is whether what kind of dentition or teeth we are using, whether they are monoplane or semi-anatomic or anatomic type of teeth. Now coming to the methods for obtaining functional support for distal extension bases. So the objective of any functional impression technique is to provide maximum support for the removable partial denture, or the RPD. This allows for the maintenance of the occlusal contacts between the natural and the artificial teeth, and at the same time it minimizes the movement of the denture bases, which would create leverage or tipping or tilting forces on the abutment teeth. So the ideal impression technique would be one in which the tissues, that is the distal extension bases, are captured in their functional form, and the teeth and the abutment teeth are captured in the anatomic form. So some tissue word movement of the distal extension bases is unpreventable and unavoidable, but it can be minimized by providing the best possible support for the denture base, that is using the maximum denture base coverage, accurate fit of the denture base to the underlying tissue, using an accurate functional impression to record the tissues in the functional state. So this being said, there is no single impression technique can be said to be superior over the other, and at the same time function from the residual ridge should be recorded by any means possible, whichever the operator may consider to be suitable for the particular case. So impression techniques are broadly classified as a physiological or functional impression technique. And second is selective impression techniques or selective pressure impression technique, which is based on the same principle of selective pressure impression techniques for complete dentures. So coming to the functional impression techniques. The functional impression techniques, as I said before, record the ridges by placing them in the occlusal load, that is they record the tissues in the functional form, and they record the teeth or the abutment in the anatomic form. Next, the various functional impression techniques to date are McLean's technique, Hindel's modification of the McLean's technique. We have the functional relining method, which is done actually just before the delivery of the denture or at the time of delivery of the RPD. And fourth, we have the fluid wax impression technique, which uses mouth temperature waxes to mold the tissues in the functional form. So next is the second category, the selective pressure impression technique. As selective pressure impression technique is the same which you have studied in complete dentures. That is, the selective load is applied to areas that can withstand the load. That is the in the maxillary, the crest of the residual ridge, the posterior lateral part of the hard palate, and in the mandibular, the buccal shelf area and the slopes of the residual ridges. So pressure is placed only in these areas, and other areas are recorded in a pressureless or minimum pressure state by the use of custom trays with proper relief wax. Now coming to the first technique of functional impression or physiological impression, which is given by McLean's, which is also known as McLean's physiologic impression technique. So McLean believed that the best way to record the tissues in a functional state is by loading them occlusally, and for this what he did was, on the diagnostic cast, record base was made, and the compound or the hard wax occlusal rims were fabricated, especially for Kennedy's class 1 and class 2 situations. And then the correlation or the bite registration was done to the patient's existing vertical dimension, and then the denture base was or was relined with impression material, suitable impression material like zinc oxide eugenol or medium body or monophase silicone impression material. And over this impression, a pickup impression was made using a stock impression tray, using alginate or a suitable impression material such as agar-agar hydrochloride. So this is how McLean's record base, or you can also call it as a custom tray, is looks. You first record the impression of the distal extension bases in a functional state by asking the patient to close on the or bite on the occlusal rim which are on top of these denture bases, and then the impression is recorded in a compressed or the occlusal under occlusal loading. And over this, once this impression is done, it is ready. Without removing this impression, using a stock impression tray and alginate or agar hydrochloride, a pickup impression is made. So the extraction bases have been recorded under occlusal loading, and the rest of the impression, that is the abutment teeth and the pickup of the functional impression, is done in a passive or anatomic state. So MacLean believed this would correlate both the functional and the anatomic impressions together seamlessly. But this was not the case in every situation, because when the pickup impression is made with the stock tray, then the finger pressure is applied to take a pickup impressions, and therefore the this impression was not very accurate. So what suggested was that he suggested a modification of this technique. So in this Hindel's technique, what he did was he created holes in the stock impression tray over the distal extension basis. So once you record the impression using in a functional state using MacLean's technique, then the stock tray was loaded with alginate or agar hydrochloride as shown in this figure, and then it was placed in the patient's mouth to pick up the functional impression. But while the impression material was setting, then a finger pressure was used to apply pressure on the wax rims through the hole that is made in the stock tray, so that both the impressions can be recorded in a functional or under occlusal loading. So this was Hindle considered to be superior to MacLean's technique, or a modification of MacLean's technique. Uh, at the either at the trying appointment, that is during the cast partial denture teeth trial, or at the denture insertion appointment, relining is done under the RPD, that is distal extension basis, with a suitable impression material such as monophase or medium body silicone. And then the denture is then flasked, and the relining impression is removed, and it is that area is filled with a fresh layer of the acrylic resin. The motive behind this is that because it is said that even though the impression may be captured accurately and the cast partial may be fabricated, it is often seen that after a few weeks or a few days, there will be settling of the denture bases, and the patient may complain that the denture base is slightly loose and it is unstable. So functional relining technique ensures that there is intimate contact of the denture base with the underlying tissues after the entire denture fabrication steps have been completed. So relining is done as a last resort, which may be done at the trying appointment or at the denture insertion appointment, and then the denture is given to the patient in the next appointment. So basically, there's nothing more to it. And then the fourth technique is the fluid wax impression technique. In the fluid wax impression technique, this is different from the functional relining technique in that fluid wax impression technique is done at the cast framework fit-in appointment. That is before the jaw relation, before the teeth setting or the teeth trying, or before the denture insertion. At the time of the once the cast partial framework has been fabricated, it is finished, polished, it is checked for fit in the patient's mouth, and once we are satisfied with the fit of the cast partial framework, we add acrylic resin or light cure resin, like record basis on the distal, that is the lattice, over the lattice minor characters of the distal extension base. And then an impression is made with mouth temperature wax such as Iowa wax number 4, Iowa wax from University of Iowa, and Correcta wax number from the University of Michigan. And this wax is then added to the wax is added to the record basis, and the impression is made. So this is the cast partial framework. First we block out any undercuts on the master cast, and then light cured resin or self cured resin record bases are attached to the distal extension lattice framework, and then the impression is taken with a mouth temperature wax by asking the patient to do various functional movements like moving the tongue, swallowing, masticating, all these things for 20 to 30 minutes. And then we get an accurate impression of the functional tissues, and then the dentures are fabricated on this. The impression is then the teeth setting is done on these trays, and that is flask, dewax, acrylize. So is the fluid wax impression technique. The next technique is the selective pressure impression technique. So selective pressure impression technique is the same as the one used for computer pictures. So there's nothing much to it. And then another technique which neither falls under the functional impression and which neither falls under the selective pressure impression technique is the altered cast impression technique. So this is an impression technique which is done after the master cast has been fabricated. All the previous impression techniques, including selective impression techniques, are taken to fabricate a master cast on which the final denture will be fabricated, except the functional relining technique, which you remember it is done after the fabrication of the cast partial denture. Whereas altered cast impression technique is a technique to modify the altered cast. That's why it is called as altered cast or corrected cast impression technique. So basically, this is a Kennedy's class 2 situation. So we take you can use selective pressure or fluid wax impression technique to fabricate the cast. Once the master cast is fabricated, the cast framework is fabricated, and same like fluid wax impression technique, on the cast partial framework, record base is made with self cure or autopolymerizing or light cure resin, and then the impression is taken, bottom molding is done, zinc oxide impression is taken of the extension situation. After this impression is then placed on the master cast which we have fabricated before. Or so what is done is the edentulous area is completely cut off from the master cast, and then the cast framework with the final impression bottom molding is placed on the master cast, and then it is stabilized on the master cast, and then a beading boxing is done, and the impression is poured only for this area, which is the distal extension base area. So this is how the boxing and beading is done, and this area will, since this is recorded in a functional state by doing bottom molding and recording the areas under finger pressure, so we correlate the master cast with this functional impression, and then the impression is poured. So this is how we get altered cast impression technique. So this is the master cast which was recorded using any other technique, and then the edentulous or a distal extensions area is captured using the cast partial framework and a record base. So this is altered cast impression technique. This is one of the most accepted impression techniques being used nowadays widely for, especially in Kennedy's class 1 and class 2 situation only we need them. The most of the other techniques are used very less nowadays. So this is how altered cast impression technique looks. So first, a master cast is fabricated using a selective pressure impression technique. You make custom trays with spacer and you record the final impression. You do bottom molding, record the final impression, and then fabricate the cast framework. And on the cast framework, we fabricate the record base, and then we take an impression with bottom molding, and then this is how the altered cast looks like. So this area, these are in two colors because the master cast has been poured in type 3 dental stone, and this the our primary focus, that is a distal extension dentures area, is poured in a type 4 or type 5 high strength dental stone or high strength and high expansion dental stone or die stone. So next, moving on to jaw relations. Now, in jaw relations, removed partial dentures are basically very easy. If only a few teeth have to be replaced, especially like Kennedy's class 4 or Kennedy's class 3 situation, which are tooth bound situation. In that case, we can just mount the casts using by hand articulation. That is by visually seeing the cast and by hand articulating the cast with each other and then mounting them on the articulator. But in situations such as this Kennedy's class 1 and class 2 situations where we don't have any distal stop or any posterior teeth, then in those situations we need to fabricate record bases with wax rims and take a jaw relation, that is at the patient's existing vertical dimension, that is when his anterior teeth come in contact, the posterior space is filled with the record base and the wax rims. So we can record the jaw relation by two methods. One is the functionally generated path or FGP, and second is the static method, which is the most commonly used method which we use in the clinics over here. So I'll tell you what the function generated path is there. In function generated path, the what so this is the functionally generated path which is mounted against the mandibular edentulous or distal edentulous cast. And according to this functionally generated path, the lower denture teeth are then set, or the trine is done according to the opposing functionally generated path. The idea being that the teeth are in a sort of balanced occlusion in complete harmony during protrusive, eccentric, in left and right lateral excursive movements. So, and this will not dislodge or put excessive forces on the edentulous residual ulnar ridges under the denture bases. So this is a dynamic method, that is all the movements are recorded and then the teeth are set. That occlusal scheme is designed according to the functionally generated path. Second is the static method which we use, that is simply we just fabricate occlusal rims on the record basis on the cast partial framework if we are doing a cast partial denture, and then bite is taken between the upper and lower softened wax rims. And once the wax rims are softened, then a top layer of the wax is removed to create space for a bite registration material, usually medium body silicone or light body silicone or zinc oxide visual impression paste is then injected between the upper and lower occlusal rims, and the patient is then again told to bite in maximum intercuspation. So this is a static record in which patient does not do any functional movement. He just closes his teeth in maximum intercuspation. This is the most widely used method and works for most of the times. And so this brings us to the end of the jaw relation for removable partial dentures. So in conclusion, there are various techniques for recording the impressions for distal extension situations, but the basic principle is similar. Anatomic impression is used to record the teeth, and a functional impression is used to record the edentulous ridges, whether it is a fluid wax technique, whether it is altered cast or functional renine, or McLean's or Hendel's technique. So basically the premise and the intention is the same, that is we need to stitch two impressions, that is a functional impression of the edentulous tissues and the anatomic impression of the dentulous areas. Okay, so that brings us to the end of this lecture.